Hi everybody, welcome back. This is going to be the first part of our new chapter, which is chapter 17. We're going to start exploring the cardiovascular system and we're going to emphasize blood. So in part 1, we're going to go ahead and take a look exactly what blood does and what it's composed of. And then we're going to spend some time talking about the function, the anatomy, and the overall development of our red blood cells, or our erythrocytes. So let's go ahead and let's get started. So the first things that we need to discuss is obviously what exactly does blood contribute to our body. And there are many functions that we can go ahead and categorize it. But most of the time what we see happening is that it falls into 3 categories. Blood is extremely useful for transport mechanisms, and this can be anything from the transport of nutrients from our digestive system through the transport of hormones, which we talked about in our previous chapter, but also the transport of our different respiratory gases like oxygen and carbon dioxide. We also see that it will play a function in regulation, and this can be different ways of taking a look at things like, for instance, body heat. Through the movement of our metabolic needs, we see that heat is being transferred from one side of the body to the other or from the inside to the other, so that will play a role in regulation. We will also talk about the fact how it can go ahead and play a role in the regulation of protein development of the liver, pH balance, and even things like vasodilation and constriction, which will then be able to regulate things like our blood pressure and our overall blood flow and distribution within our entire body. And then last but not least, the third category within the function would be protection. And really within protection, we're looking at our leukocytes, or our white blood cells, which will have a specific role in our immune system for protecting us against a wide array of different pathogens. And also we should mention our platelets, which will be our cell fragments that will play a very important role in hemostasis, or blood clotting. Now, as we peruse through the chapter, we're definitely going to be mentioning these functions over and over again, and then you'll be able to see which specific cells will play specific roles in the overall function of blood. Now, in case you were wondering, blood is classified as a tissue. It is a connective tissue. Some of you might remember that from your 2085 histology section. It is the only tissue that we have in our body that is actually a fluid. And what we see happening is when we take a look at the composition of blood, it is going to be a mixture of fluid and formed elements. Now, the fluid will be called plasma, and plasma is mostly composed of water. This will be the liquid aspect of blood. And then the formed elements are going to be the cell and the cell fragments that we see suspended within the plasma. Now there are 3 different formed elements. We have our erythrocytes, which are our red blood cells, or RBCs. We have our leukocytes, which are going to be our white blood cells, or WBCs. And last but not least, we have our platelets. Now, our goal should be by the end of this chapter that we fully understand how each of these formed elements is formed, as well as what their overall function is going to be within the body. And each of them will have a very specific role, which is partly what makes it so interesting when we discuss the composition of blood. Now, a very old school technique that is still utilized today to kind of separate the plasma from the formed elements in a whole blood sample is called a hematocrit. So let's go ahead and click over to the next slide, and let's get a visual in here so we can take a look at what a hematocrit actually entails. All right, so when you do a hematocrit, what you're doing is you're collecting your patient's blood sample, and we're going to utilize a centrifuge to basically separate it into its different components. And what a centrifuge does is it just kind of spins at a very high rate, and as it's spinning, it allows the heavier items to kind of fall to the bottom, and then the lighter items to kind of drift on top. And what we see happening now is at the end of our centrifuge cycle, our whole blood sample will be divided into the plasma option towards the bottom. So this will be kind of like the clearish, actually it's more of a yellowish liquid that you see up here, usually about 55% of your sample. And then you're going to have a nice bright red layer that's at the bottom. And this is going to be our erythrocyte sample, which usually takes up about 45%. And the percentages will vary, especially depending on the overall body size of your patient, if the patient is anemic, also if the patient is actively fighting off an infection. And what I mean with that is that normally what you would see is that you would have this tiny little buffy coat that sits between the red blood cell section and the plasma section. And this buffy coat, you can see it right here. I'm going to try to draw an arrow to this narrow edge right here. This buffy coat is where we will find our leukocytes and our platelets, so our white blood cells and our platelets. And from our hematocrit, we can see that the white blood cells and the platelets only make up a small percentage of our circulating bloodstream. And we're going to talk about why exactly that is happening. But in someone who is ill or recently has been ill, what we usually see is that buffy coat is a little bit thicker because they'll have elevated levels of leukocytes or white blood cells to indicate the activation of the immune system. Now, in a typical hematocrit, what you would be interested in is really the percentage of red blood cells, but as you can see, you can also figure out the percentage of plasma as well as the percentage of leukocytes and platelets. Now, if we were to go ahead and give a physical characteristic of blood, we would say that it tends to be a little bit sticky. It has a more like a yellow, opaque fluid. If you're interested in the taste, it tastes a little bit metallic. Part of that is because of the iron that's being carried within the red blood cells. And we would also see that blood is, because it is sticky, it has a higher what we call viscosity level of water. Viscosity is basically a stickiness of a fluid, how easy it is to move from point A to point B. Water tends to have a low viscosity point, meaning that you can easily transport it, whereas blood tends to have a higher viscosity point. And this is all due to the fact that blood is composed of a mixture of fluid and mixed and formed elements. So the interaction of the red blood cells, the white blood cells, and the platelets within the plasma actually makes it a little bit stickier and kind of slows it down as it's flowing. The color of blood can vary in different shades of red. A lot of that will be to do with how good the blood cells are. How good the red blood cells are at carrying oxygen molecules. And in a little bit, we'll talk about the fact that that carrying capacity will have to do with the amount of hemoglobin and iron that each red blood cell carries. Either way, what we usually see is that if the patient has a high level of oxygen that's being transported within the bloodstream, the blood that's being collected is going to be more of a scarlet red color, whereas the low oxygen level tends to be more of a darker shade. Blood is considered a neutral solution. Its pH falls right below right between 7.35 and 7.45. And if we're looking at how much blood you actually have, what we usually see is that on average, males will have between 5 to 6 liters and females between 4 to 5 liters. So I wrote down on your slide why, as in why is it that females have less blood than males? A lot of this has to do with body size. Statistically, it is more common for females to have a slightly smaller build than most males, and because the body is smaller, it will require less blood. But we also see that hormones play a role in this, and studies have shown that because males have higher levels of testosterone, testosterone actually stimulates a higher rate of red blood cell production. So because males have more testosterone, they tend to have higher levels of red blood cells. For females, another thing that will play a role in the lower number is the fact that many females will lose quite a bit of blood on a monthly cycle due to their menstruation. So those are just some of the explanations as to why males and females will vary. But keep in mind that overall what we see happening is that the amount of blood will be directly related to your overall body size. The larger you are, the more blood you're going to require for all their different functions that it contributes to your homeostatic functions. Now let's take a look at the plasma. So as I said to you before, the plasma is mostly composed of water. And within the plasma, besides the formed elements, you will have different items floating around. So studies have shown that there's over 100 different solutes, and these can be things like hormones, waste products, inorganic ions, nutrients that are just kind of floating around within the plasma itself. But one thing I definitely want to mention that is very important is that the most abundant solute, so the most abundant particle that we find within the plasma are actually plasma proteins. And plasma proteins, the majority of them are being produced by the liver. They play many different roles, but the one I want to focus on is albumin. Albumin is the most common plasma protein that you will find floating around in your bloodstream. And what we see happening with albumin is that it can go ahead and have functions like carriers of other molecules. So think back to chapter 16 when we were talking about the fact that there is a category when we look at our hormones that can be hydrophilic and hydrophobic. Well, some of the hydrophobic hormones will actually piggyback on albumin to get over to their target cells. It can also play a role as a blood buffer, and also what we see happening is that it will contribute to the osmotic pressure. So the osmotic pressure in your plasma will basically help move solutes from the inside of the bloodstream to the outside of the bloodstream. So obviously these are things like an isotonic, hypertonic, hypotonic situation. We want to make sure that we have more of an isotonic consideration, meaning that we have very similar environments inside the blood vessel than as well as outside, so that we can have an easier time regulating our overall blood pressure, as well as quantity of volume of the plasma and the formed elements inside the blood vessel, and not place too much stress on it. Now, keep in mind that a lot of these proteins are being produced by the liver, so that means that if we're looking at patients that have cirrhosis or any type of liver abnormalities, another side effect of it would be that we would have to consistently take a look at their overall blood quantity, because as you can see, if the liver shuts down, it will also severely reduce the plasma proteins, which will then also affect the tonicity of your bloodstream. Now for our formed elements, as I mentioned to you before, we have three options. We have our erythrocytes, which are our red blood cells, and you can see them pictured here in the illustration on your right-hand side. We have our leukocytes, which are our white blood cells, and then we have our platelets. Now, out of these three options, it turns out that our white blood cells are the only what we call complete cells. And the reason we call them a complete cell is because they will maintain their nucleus from the beginning to the end of their lifespan. Red blood cells will lose their nuclei as they become mature, as well as the majority of their organelles. Platelets are not really considered cells, they are more cell fragments. Now, as we start talking about the red blood cells, the white blood cells, and the platelets, we'll go into more detail, and we're definitely going to go ahead and explore why the red blood cell has to lose its nuclei and most of its organelle, and why platelets are considered cell fragments and actual not cells. At the bottom picture, what you can see is the interaction between the formed elements, and you can see your erythrocytes, as we were chit-chatting when we talked about the hematocrit, are the ones that are in the highest quantity. Your white blood cells are scarce, but as you can see, you have different versions of your white blood cells. So I went ahead and I circled the neutrophil, the eosinophil, here's the lymphocyte, there's a monocyte, and we're missing one. That one's called a basophil. So we're going to talk about the 5 different categories of white blood cells. Notice how they are larger than the red blood cells, and also notice how they have a nucleus. The nucleus is the part that is, and I'm going to go ahead and highlight it here on the monocyte. The nucleus is the part that is stained purple. Okay? And then the platelets are really hard to see on this picture, but they're just tiny little dots representing the smallest part of the formed elements, the little cell fragments. Most blood cells will originate from the bone marrow and they do not divide, so we see that throughout our lifespan we will rely on stem cells within the bone marrow to consistently produce our formed elements. Alright, so let's start focusing on our erythrocytes, on our red blood cells. And let's talk a little bit about some of their structural characteristics. So first off, they're very small in diameter. Most red blood cells are just small enough to fit into the narrowest capillary. If you were to look at the cell shape, and I'll show you a picture in just 1 second, we would see that it has a little dip, which we like to call a biconcave. It has a dip both on top as well as the bottom. As the red blood cell becomes mature, it'll actually start flattening out and it will start emptying out its content so it can get as flat as possible. So what we see happening is that it will lose its nucleus, so it will become an anucleated cell when it's mature, and it will also get rid of the majority of the organelles that it has inside of it. In fact, red blood cells actually do not rely on oxygen for their cellular respiration. They do anaerobic respiration, so they don't utilize their oxygen to produce ATP for their own individual cell. Now remember, the whole goal of a red blood cell is to carry as many oxygen molecules as it possibly can. And this is the reason why as it matures, it will flatten, it will get its little biconcave, its little dip on the bottom and on the top, and it will lose the organelles that are inside of it. It will, however, hold on to what we call hemoglobin. And it turns out that the hemoglobin is going to act almost like a little magnetic force that's going to allow the oxygen molecules to kind of be drawn to it so that the red blood cell can freely interact with the O2 molecule and transport it from point A to point B. But I'm getting a little ahead of myself. I'm going to talk to you more about hemoglobin in a few slides. So let's see what else we got going on with our red blood cells. Oh, something very important that's mentioned on this slide. It turns out that inside of the cell we have a very important plasma membrane protein called spectrin. And you want to remember this name because it turns out that this protein is going to give a lot of flexibility to the red blood cell so it can squeeze itself into small capillaries and it kind of like have fold itself in half just to make it easier to kind of be a little bit more flexible and obviously to go ahead and increase its oxygen carrying ability. Here is just a very simplistic view of our red blood cell. We can see that it's relatively small and notice how it has the dip. So this is our little biconcave that we were talking about, and that's going to help flatten out the cell, create more surface area so it can carry more oxygen molecules. Alright, so as I said to you before, the function of it is primarily respiratory gas transport. And it's really more interested in oxygen than carbon dioxide. That's its real gas that it's trying to term. Now, in order to do that, it's going to rely on that hemoglobin that we find within its cytoplasm. And hemoglobin is basically composed of a few elements. We see that it has what we call a heme pigment. This is going to give the color to it, and it's going to have a protein section that we're going to call the globulin. Now, the globulin is going to be composed of 4 polypeptide chains. You're going to have 2 alpha chains and 2 beta chains that will work together, and we'll see that at the end of each of the chains, you're going to have the little heme pigment that sits there. Now, the heme pigment is very important because it turns out that in the middle of the heme pigment, we're going to put a little iron atom. And this iron is going to form that magnetic force that's going to allow the oxygen molecule to be attracted to the hemoglobin. There are millions of hemoglobin molecules in each red blood cells. So what we see happening is that each of these hemoglobins will be able to carry 4 oxygen molecules at max. Now, how did I get to this number? Well, I got to the number 4 because we know that each hemoglobin is composed of 2 alphas and 2 betas. So that gives you your 4 polypeptide chain, and each polypeptide chain has a heme pigment with iron at the end. So at maximum carrying capacity, we can do 4. And don't worry, I'm going to show you an illustration for those of us who are trying to visualize what this hemoglobin looks like. I also want to share an interesting fact with you. It turns out that if you take a look at the hemoglobin of a fetus, so when the baby is still in vivo in mom, excuse me, what we see happening is that the hemoglobin is slightly different of the unborn baby. Instead of having 2 alphas and 2 beta chains, their hemoglobin will have 2 alphas and 2 gamma chains. And it turns out by swapping out the beta with the gamma, you actually increase the pull of oxygen towards the hemoglobin. Now, why would this be important? Well, remember that as the baby is being developed, it gets all its nutrients and oxygen from mom. So it literally has to pull the oxygen molecule from mom's bloodstream into its own bloodstream. And if the hemoglobin had the same magnetic force, the fetus really wouldn't win. So instead, what we see happening is that it develops a hemoglobin that has a stronger pull due to the switching of the beta chains into the gamma. And by doing so, it's able to freely, I'm going to say steal, but it's really taking the oxygen molecule from mom's bloodstream into its own bloodstream. Now, once the baby is born, what we see happening is that over time, its red blood cells will go ahead and swap the gamma out for beta, and we see that the hemoglobin will then return to its stereotypical construction of having 2 alphas and 2 betas. And part of that is because obviously it no longer has to compete for oxygen with its mother. Here is a look at what hemoglobin looks like, and as you can see, we have 2 different shades of brown. The darker shade of brown represents our beta globulin chain, and notice how at the end of it you have this little red dot, right? This little red circle, that's going to be our heme group, and here in green, that's our iron molecule. The lighter shade, I guess this would be like a khaki, I guess, those represents the 2 alpha globulin chains, and as you can see, you have 1, 2, 3, 4 heme groups representing the end of each of the globulin chains, and at each of them you have the iron indicating that you're able to carry 4 oxygen molecules per hemoglobin. So right over here it says each hemoglobin molecule can transport 4 oxygen molecule, and in case you're wondering, as I said to you before, it has millions of it, but here it has a more specific number. On average, a red blood cell has over 250 million hemoglobin molecules, so it's a massive amount of oxygen that these biconcave cells can carry. In fact, what we see happening is that oxygen that actually binds to the lungs, that will actually bind to the hemoglobin, we like to call those oxyhemoglobin because it indicates the interaction between the oxygen and the hemoglobin. And that usually will go ahead, its interaction with the iron will give that beautiful red color that we were previously talking about. Oxygen also needs to unload, needs to disconnect, and when it does so, we call it deoxyhemoglobin. So if you see the term oxyhemoglobin versus deoxy, it just indicates if the oxygen is actually attached to the hemoglobin or if it's starting to pull apart because it's trying to be unloaded. And this can cause a change in the overall color development of the bloodstream. In case you were wondering, what about carbon dioxide? It turns out that the majority of carbon dioxide actually is more of a free-floating molecule, so it will freely float in the plasma, whereas there are a certain percentage, about 20% of the carbon dioxide molecule that does like to bind to hemoglobin. However, it will bind to a secondary site, not the same site as oxygen. And when we see that interaction between carbon dioxide and hemoglobin, we call it carbaminohemoglobin. All right, so where do we get these red blood cells from? And in order to do that, we have to explore hematopoiesis. Hematopoiesis is the formation of all blood cells, and what we're going to do is we're going to focus specifically on our red blood cells. And it turns out that the story will always start in the same location, which is that we have to go over to our red bone marrow. And within this red bone marrow, which we tend to find as adults in like our axial skeleton, the girdles, like our pectoral girdle or pelvic girdle, also the epiphysis, which are the end part of the humerus and the femur bone, those are stuffed full with red bone marrow. And within that marrow, we have what we call hematopoietic stem cells. Now, a stem cell is basically an undifferentiated cell, a cell that doesn't have a function. So depending on what type of stem cell you're looking, you can have stem cells as adults that will give you the option of becoming several different cells, or you can have a stem cell that can only become one specific type of cell. This will all depend on mostly which hormonal or chemical messenger it receives so that it can go ahead and become what we call a committed cell. A committed cell is a cell that knows what its overall function will be when it develops into its adult form. Now, for our formed elements of our blood, we see that we have to go over to the red bone marrow and we have to look for our hematopoietic stem cells. And these hematopoietic stem cells will give rise to the red blood cells, to the white blood cells, and the platelets. The way the stem cell will know which formed element to do will depend on which hormone and growth factor it is exposed to. When it's exposed to a specific hormone or a growth factor, then the stem cell is converted into a committed cell, meaning that that cell knows exactly when it reaches maturity, it's going to be a red blood cell, a white blood cell, or a platelet. So part of what we have to discuss in our little lecture series is what exactly is the hormone, or what exactly is the chemical messenger or the growth factor that's required to get each of these formed elements to be produced within the body. Once the blood cells reach a certain level of maturity, we'll see that they will leave the bone marrow and then they'll be dropped in blood sinusoids, which are huge collecting parts. And from there on, they will basically be distributed through the bloodstream and they'll make their way throughout our entire body. So let's take a look at this illustration right here. This is going to take a look at erythropoiesis, which is exactly how do I make my red blood cells. And this picture is very important because it's going to show you how you can take a hematopoietic stem cell that you find in your red bone marrow and you can make your way through different morphologies and different types of cells to get to your mature erythrocyte or your red blood cell. This whole process that you're looking at is going to take about 3 to 5 days. So let's work our way through it and let's see how can we produce our red blood cells. So remember, we're going to start off with a hematopoietic stem cell in our red bone marrow. And then the first thing is that we need to go ahead and make sure that the cell becomes a committed cell. And a committed cell means a cell that knows what its function will be when it's an adult. And in this case, the way that we're going to go from stem cell to committed cell is we're going to rely on this hormone called erythropoietin. EPO for abbreviation. Now, erythropoietin is mostly produced by the kidney, and the kidney will secrete it. The hormone will travel over to the red bone marrow, and it will convert the stem cell into a committed cell. In this case, the committed cell will become a red blood cell. Now, in order to go from a committed cell to a mature red blood cell, there are 4 things that we need to do. We need to reduce the size of the cell, so the cell needs to get smaller. We need to proliferate the cell, meaning that we need to make multiple copies of it, because remember our goal is to do erythropoiesis, to produce lots and lots of red blood cells. We need to go ahead and synthesize hemoglobin. And last but not least, we need to get rid of the nucleus. So these are the 4 steps that you're looking for to go from committed to red blood cell. Now what we see happening is, what we're going to do is we're going to call the cell between a committed cell and a mature red blood cell. The first cell that we're going to come across, we're going to call it an erythroblast. And when you look at connective tissue, oftentimes the cells, when they're in development stages, so they're not fully mature yet, they'll tend to end with blast. And you're going to see that in the leukocytes and the platelets as well. So an erythroblast cell is a developmental red blood cell. It's on its way to become mature, but it's not quite there yet. So as you can see, you're going to see some morphological changes occurring. And honestly, I don't think there's a need for you to memorize basophilic erythroblast, polychromatic erythroblast. You don't have to worry about it. I just want you to know it's called an erythroblast. And I want you to know that when the cell is in its erythroblast developmental stage, it is going to start reducing its cell size. It is going to proliferate, meaning it's going to make multiple copies of itself, and it's going to start synthesizing hemoglobin. Okay, so it's going to be doing 3 of the 4 steps within its erythroblast activity. And then what we see happening is that it will eventually lose the nucleus. You see my little nucleus right here? It's being ejected. And when you lose the nucleus, we're going to change the name, because when it loses the nucleus, we're no longer going to call it an erythroblast. We're going to call it a reticulocyte. And the reticulocyte, besides being known for the fact that it's then lost or discarded its nucleus, will be the first cell that will leave the bone marrow and will go into the blood circulation. And from there, it will take another day or so for the reticulocyte to fully mature into an erythrocyte. All right, so let's do this all over again. So if you're doing erythropoiesis, it's going to take you about 3 to 5 days. You're going to start off with a stem cell. That stem cell will be exposed to erythropoietin, EPO, that's our hormone, and it will allow the stem cell to become a committed cell. A committed cell now knows it's going to become an erythrocyte because it's been exposed to EPO. After it becomes a committed site, we're going to go ahead and form our erythroblast cell. The erythroblast cells are going to reduce in size. They're going to proliferate, meaning they increase in number, and they're going to synthesize hemoglobin. Then they're going to go ahead and lose their nucleus. And when they lose their nucleus, we're going to call them a reticulocyte. The reticulocyte is the first cell to leave the bloodstream and start circulating around, and it takes another day or so for it to fully mature into an erythrocyte. So now you have your mature red blood cell that you have access to that can do all the gas transport functions that we were previously discussing. The average lifespan of an erythrocyte is about 120 days, and the reason for that is because it turns out that that flexible protein, spectrin that we mentioned previously, it has about a 120-day lifespan. After that, the spectrin kind of runs out, and the erythrocyte loses its flexibility, which means that when it tries to squeeze into those small capillaries, it will actually pop open and be destroyed. It's very important for your body to regulate the quantity of red blood cells, because what we see happening is if you don't have enough red blood cells, then it reduces your amount of oxygen that you can carry, which means that it can lead to tissue hypoxia, which means low levels of oxygen saturations within the various tissues. If you have too many red blood cells, then what we see happening is that they take up too much space in our blood vessels, and they will increase your blood viscosity, the stickiness of the blood. So it will make it harder for blood to stream from point A to point B, which means you increase your blood pressure, and it also puts a strain on the heart, which obviously could be very detrimental. Now, if you look at the numbers, your body makes around 2 million red blood cells per second. So you have a huge quantity of red blood cells that are floating around. So your body does have a very important task of regulating these high quantities of cells. And mostly what it will do is it will rely on hormonal controls. So we're thinking about our EPO or erythropoietin, and it will also rely on certain dietary requirements to make sure that its erythropoiesis process can be done successfully. Now go ahead and take a look at this illustration right here. And this illustration basically talks about the fact that we can use hormonal controls, as mentioned previously, to control how many red blood cells we have floating around. And usually what we see happening is that if you have an imbalance in your homeostasis, and in this case you have an imbalance, we can start on this side right here, where you actually start to dip below and you have hypoxia, not enough oxygen being delivered, we see that one of the first places that will detect this will actually be the kidneys. And there's a reason why that it goes there. It turns out that it is easily detected by the kidneys because the kidneys are able to produce erythropoietin, EPO. Your liver also produces EPO, but just in a smaller quantity. The kidneys are really the main ones. So the kidneys will be the first one to detect that the body's not getting enough oxygen. So what it will do is it will start secreting EPO. The EPO will hop on into the bloodstream. It will travel over to the red bone marrow. And then just like we saw in our little pictures, it's going to allow for the stem cells to become committed cells, to become erythroblast cells, to become reticulocytes, and eventually what you see happening is that you have a higher level of mature red blood cells that are floating around. And the more red blood cells you have, the more hemoglobin you have, which means the higher amount of oxygen you can carry. So you get rid of that hypoxia, and by doing so, you reestablish the homeostasis within the body. So this would be a perfect example of hormonal control of red blood cell production. I'd also mention to you that there are some dietary requirements that are needed for successful erythropoietin. Part of that will be things like making sure that you have enough amino acids, lipids, and carbs that are floating around. But the real important thing is the fact that you have enough iron, because your iron needs to be bound to the hemoglobin to have that successful magnetic force so that your oxygen can be attached and carried from point A to point B. Now, a few things about iron. It turns out that if you have free iron molecules just kind of free floating in the bloodstream, it can be very toxic. So what your body likes to do is it likes to store some of it as ferritin and hemodesirin. It will also use a transport protein called transferrin whenever it needs to move the iron within the bloodstream to make sure that it actually gets to its final destination. And if by any reason you have any excess iron, your body will just simply shut it off and it will literally just be discarded in your fecal matter. In fact, if you've ever taken iron supplements because maybe you were anemic and it was recommended that you increase your iron level, what you see is that if your iron supplements are too high in their concentration, one of the side effects you're going to notice is that your fecal matter will actually turn a very dark color, and the reason for that is the excess iron. Some people will also complain about things like stomach aches, or they might become constipated, and that's because having excess iron can also upset your water balance. So if you're currently taking iron supplements and you have constipation, your stomach hurts, your fecal matter is like this really dark color, what you can try to do is half the dose of iron that you're taking, and that should usually get rid of a lot of the symptoms that you're experiencing. And part of that all has to do with the fact that your body just doesn't like to store a lot of iron. It just uses what it needs and it discards the rest. Another thing you can do if you are feeling a little lethargic and you've been diagnosed as anemic is that you can basically stock up on your vitamin B12 and folic acid. And these two are very important because it turns out that they help with DNA replication and synthesis, which tends to speed up the development of our red blood cells. So I said to you before, lifespan is about 120 days. The book goes ahead and gives you a range from 100 to 120. For exam purposes, we're just going to consider it 120. I'm going to scratch this out, and as we discussed before, a mature red blood cell will be anucleated, and because it doesn't have the nucleus, it can't repair itself or it can't grow, it can't duplicate itself, and that is why we keep relying on that red bone marrow to produce our formed elements over and over again. Now, remember that the main reason why we have a lifespan for our red blood cells at 120 days is because spectrin starts to be depleted, And as the spectrum protein starts to deplete, we see that the red blood cell loses its flexibility. So when it tries to squeeze in those very small capillaries, it will literally not fit and it will pop open. And it turns out that this tends to happen a lot more often at the spleen than at any other part of the body. And that's because the spleen is filled with some of the smallest capillaries that we house. And because this tends to happen at the spleen more often than anywhere else, the spleen is also known as the erythrocyte graveyard, because that is where the old red blood cells tend to pop open and be fully destroyed. Now, what exactly happens to a red blood cell when it pops open? Well, it turns out that part of it will be engulfed by macrophages, which are these large white blood cells that will just come around and they'll chew up the membrane of the red blood cells. And then we also have to go ahead and do some additional steps to get rid of our hemoglobin and see how we can recycle some of the materials that they are composed of. So here, it says when you do your red blood cell breakdown, keep in mind that you have to get rid of the heme, the iron, and the globulin. That was your hemoglobin. And some of it's very easy to get rid of. So the iron, what we're going to do is we're going to go ahead and bind it to a protein, and we're going to store it or we're going to reuse it, and we're going to transport it over to where it's needed, most likely the bone marrow, so it can be recycled into some new red blood cells. The heme, that's your pigment, tends to be degraded to more of a yellowish pigment, and that pigment is called bilirubin, and it gets its name because it's excreted by the liver. So the liver will be able to pick up the heme and it will recycle it into bile, and it will then go ahead and produce more of a yellowish, so the bilirubin. And what we see happening is as the bile is being released along with the bilirubin yellow pigment, it will travel through the intestines where it will eventually start interacting with the other components within your large intestines, and the pigment will actually be broken down into what we like to call urobilinogen. Urobilinogen will interact with your fecal matter, and it will actually cause your feces to turn the brown pigment that we're so used to. So here's a little, I think, a fun FYI. You might not think so. But if you didn't have bilirubin and you didn't have urobilinogen, your fecal matter would actually be more of a white, grayish color. So if you're into colors, I guess, just a little FYI. All right, and then of course the other part of our red blood cell, or I should say the other part of our hemoglobin, are the globulins, our 2 alpha and our 2 beta chains. Well, those are the easiest to get rid of because since they're protein based, what your body will do is it will simply break them back down into amino acids, and as you know, your body uses amino acids for a wide variety of items, so it's just released back into the bloodstream and it goes over to wherever it might be needed. Maybe it's needed for muscle building or muscle maintenance, for instance. Now here's a really nice image. This is figure 17.7, and it basically takes a look at the life cycle of the entire red blood cell. So it starts off with the exact production of the red blood cell, so erythropoiesis, and then it kind of walks your way through what happens whenever you have an aged or damaged red blood cell, and how you kind of break down the different components and what happens to the building blocks of it. So let's take a quick look, and I know it's a little bit small, so keep in mind that you can always reference it in your book, or you can kind of zoom in, see what's happening. But on top we see the mentioning of the fact that the kidneys are often the first location where hypoxia is noticed, so that they can go ahead and release erythropoietin. That is our hormonal stimuli that we see will travel through the bloodstream and will go over to the red bone marrow, where it will interact with our hematopoietic stem cells, and within 3 to 5 days it will produce new red blood cells that will be dropped off into the bloodstream. And as the bloodstream cycle around, they have about 120 days where they can enjoy the flexibility of their spectrin protein. After that, we see that they'll try to squeeze into a small capillary and they'll pop open and be destroyed. And this tends to happen more often in the spleen. That is why we call it the erythrocyte graveyard. And then it gets a little interesting because it's going to give you a full breakdown of what exactly we do with the components that make up a red blood cell. So over here for number 5, it tells you that the actual membrane is going to be engulfed by a macrophage, and then the hemoglobin is going to take a little bit more work to be broken down. So you can see your little hemoglobin. You can see that the globulin, the protein aspect, is broken down into their amino acids. That goes right back into the bloodstream so that we can recycle it for other functions. The heme itself is going to go ahead and get rid of its iron. We got to get rid of the iron. And we can store a little bit of it and we can transport some of it, but either way it will be released back into the bloodstream and it will go ahead and most likely be used for erythropoiesis all over again, or any other requirements that the body might have for the iron molecule. And then the actual pigment will be then converted into bilirubin, and as you can see, the liver will interact with it to produce its bile, and as it then travels over to our large intestines, we see that the urobilinogen will come into play, where it will then interact with the bacteria in our large intestines, and it will contribute to the brown fecal color that we're so used to seeing. All right, I really like this diagram, and it really is it's a nice tool, especially for those of us who are more on the visual side, and we really want to see how the journey starts from beginning to end. Now, the last few things I want to touch up on this particular part of our lecture is some of the erythrocyte disorders. So what happens when you just don't have the right quantity of red blood cells from a clinical application point? And what we see happening is that you can either have not enough or you have too many red blood cells. So what we see happening is that we can classify it as anemia or polycythemia. Anemia falls into this large category when the blood simply has an abnormal low amount of oxygen carrying capacity. And this can be caused by many different ways. One of it could be that you're simply low on iron, which is actually a very common problem amongst a lot of us. And if you don't have enough iron, as you now know, you're not able to have that magnetic force of the oxygen being attached to the red blood cells, which means that even though you have enough red blood cells and you're inhaling oxygen, you're simply not able to carry the oxygen to where it's needed. So in most cases of iron deficiency, it can be resolved by taking an iron supplement. Obviously, there's also some clinical ways that can be increased if over-the-counter stuff is not sufficient for the patient. The other thing that we see happening with anemia is that it can be caused by severe blood loss. So if a patient, for instance, goes through a trauma, let's say, for instance, they get into a horrible car accident and they lose a massive amount of blood, that can put their body into the anemic category because they don't have enough red blood cells. We also have cases where your body is not, for instance, responding to EPO, which means that you have a hard time producing enough red blood cells. So that can be another reason why you would be anemic. You're not producing enough red blood cells. And that can be an abnormality with maybe your bone marrow, with your kidneys not producing enough EPO, but it could also be on the nutritional side where you don't have enough things like your folic acid or your B12, as mentioned before. You can also have a scenario, for instance, like certain poisons that will allow the red blood cells to be destroyed in a high quantity. So if there's too many red blood cells that are being destroyed within a relatively short period of time, that can also cause low oxygen carrying capacity. And like I mentioned to you before, as you can see at the bottom of the screen, low iron level is one of the main causes of anemic issues. The symptoms of anemia usually include things like fatigue, pallor, which means that the skin turns more of a whitish color. You might have some abnormality with your breathing rate, and some people will report the fact that they get chilly very easily. The opposite of the anemic disorder will be polycythemia. Polycythemia is when the body is producing an excessive amount of red blood cells. And as I previously mentioned, this is going to be a problem because it's going to increase the viscosity of the blood. making it harder for blood to flow because it becomes more sticky. And this can put extreme pressure on your bloodstream as well as on your heart. It can actually increase your chances of having a heart attack, having a stroke, or having a floating blood clot. So it can be a very dangerous disorder. Polycythemia tends to be divided into two categories. You have what we call primary polycythemia, or as the slide refers to it, polycythemia vera. This means that the excessive red blood cells are unfortunately being produced because your bone marrow has a cancer, which is causing the numbers to increase. In fact, there have been reports that patients that suffer from primary polycythemia can have a hematocrit that's as high as 80%. Now, a typical hematocrit will run in the 40s, so it's almost double the amount of red blood cells than you actually need. And one of the main ways that they treat this is through a phlebotomy, meaning that they'll go ahead and, very similar to a blood donation, they'll have the patient come in and they'll draw out the excess red blood cells, all in a way to reduce the numbers of red blood cells floating around and thereby also reducing the viscosity of it, so taking off less pressure on your blood vessels and the heart. The other category for polycythemia is what we call secondary polycythemia. And as it says on your PowerPoint right here, it's caused by low oxygen levels as well as an increase in EPO production. But basically what that means is that secondary polycythemia tends to be more of a lifestyle change that's occurring that causes your body to temporarily have high levels of red blood cells. So for instance, things like being exposed to an environment at a higher altitude. So maybe, for instance, you decide that you want to travel to Aspen because you want to go skiing. When you get there, the air is thinner, it's a higher altitude. So what your body will do is it will notice that it will have a harder time drawing in enough oxygen, so it will temporarily increase its red blood cell production. And that would be an example of secondary polycythemia. When you return back to Florida or wherever you're going, what we see happening is that the excessive red blood cell numbers will dwindle down by themselves and you'll go back to your normal red blood cell. Things like emphysema can also cause a secondary polycythemia, and this all has to do with the fact that your body is once again being exposed on a environmental reason to low oxygen levels. All right, I think this is where we're going to stop for part number 1 of chapter 17. So let's go ahead and please, let me just encourage you, if you have any questions, comments, and concerns, feel free to email me. Please use the discussion sessions. Please go ahead and make sure that by the end of part 1 that you are very familiar with the functions of our erythrocytes. You definitely want to focus on the developmental pathway of it, so the erythropoiesis. Also be able to tell me what happens after 120 days. How do we get rid of these old fragmented red blood cells? So take your time, go through the material, and if you have any questions or concerns, definitely reach out. And then whenever you're ready, go ahead and migrate over to our second part of the chapter. That one is going to take a look at our white blood cells, and we'll talk about the different variations you have, and of course how they function differently from each other. It's going to be some fun, I promise. All right, talk soon.